Good evening, everyone. Thank you so much for joining us tonight. We welcome you to the first ever Health Equity I Can Make a Difference conference. My name is Olanefe Akinmalayan, and I'm currently a P4 here at the University of Findlay. I'm from Aurora, Illinois originally, but I am delighted that my journey has led me to be here with you all tonight. It is my hope that tonight you will all open your minds to the knowledge that you will be receiving. With your attendance tonight, you are making a major step in influencing change in your respective communities. Tonight, we are honored to have Dr. Regina Benjamin, the 18th U.S. Surgeon General, also known as America's Doctor. Are you ready? Drop a yes or a I'm ready in the chat right now. Yes, we love to see it. Looks like the juices are flowing. And so I'm going to hand it over to Carmen to give us a little bit more about how this all started. Carmen?
Thanks, O. Hi, everyone. My name is Carmen. I'm a current P6, and I'm living in Dayton, Ohio this year. I wanted to give you guys a little bit of background about who we are and this event tonight. So a student group formed this past summer, started with just a group chat, and we all were just talking about some of the experiences we had in rotations and how we really felt that we wanted to be able to help patients more, especially coming from different backgrounds and from underserved circumstances. So we came together and brainstormed an idea for an event that was could be educational, but also a celebration of diversity. So that we all came together, and that's why you're here tonight, and we're excited for the future of this event and the years to come. Thank you so much. And I'm going to pass you guys on to Gloria, another student in the group. Thank you.
Hello, everyone. My name is Gloria Gimanju. I'm also a FAMD candidate of 2021, and I am originally from Central Africa, precisely Cameroon. And we are very excited to have everyone on this platform today. This is a very important event for all of us today. We're going to have a chance to learn on what to do to help our patients and how to work towards health equity. And also, this is just the start of diversity and inclusion within the College of Pharmacy. Thank you, everyone, for coming. And with that being said, I'll pass it over to Cody.
Thanks, Glory. As she said, my name is Cody Beavers. I'm also a P6 in my final year of pharmacy school from North Canton, Ohio. I just wanted to go over a couple of quick things with how the webinar is going to work. We're going to have Dr. Benjamin speak, but if you guys have questions in the Q&A section down at the bottom, you're able to submit questions, and then we'll go over those later after she's done speaking. Also, for your information, the program will be recorded tonight, so if you wanted to watch it back, or if you need to go at any point, you can take a look at that or send it to your friends. If you have any issues, need any tech support, we do have someone for that. You can email Rebecca Jenkins at jenkinsr1@findlay.edu. And with that, I'm going to pass it over to Sarah to introduce Dr. Fell.
Good evening, everyone. My name is Sarah Crisp. I am also a P6, completing my very last rotation in Cleveland, Ohio currently. But I'm very excited to welcome Dr. Fell. Dr. Catherine Fell has served as the president of the University of Findlay since July 1st, 2010. She's the university's 17th president and first female president since it was founded in 1882. President Fell holds a Bachelor's of Science in English in Education in English with a minor in speech from Southern Arkansas University and a Master's of Arts in English from Louisiana Technical University. She also completed a PhD in English from Texas A&M University. President Fell is known for her deep commitment to providing an outstanding learning environment for us as students, respect for the university's culture of shared governance, and passion for supporting the community and having a supportive leadership style influenced by a touch of Southern grace. Her vision for the University of Findlay has created renowned focus on experiential learning and intercultural understanding, allowing for student-led events like tonight's. So please welcome Dr. Fell to tonight's event.
Thank you, Sarah. It's my privilege, of course, to introduce the star of tonight's program. Dr. Regina Benjamin, the founder and CEO of Bayou Clinic, was the 18th United States Surgeon General, serving from 2009 to 2013. As America's doctor, she provided the public with the best scientific information available on how to improve the health of the nation. Dr. Benjamin also saw the operational command of 6,500 uniformed public health officers who serve in locations around the world to promote and protect the health of the American people. As chair of the National Prevention Council, comprising 17 cabinet-level federal agency leaders, Dr. Benjamin led the development of the National Prevention Strategy, America's Plan for Better Health and Wellness. From her early days as the founder of a rural health clinic in Alabama to her leadership role in the worldwide advancement of preventive health, Dr. Benjamin has forged a career that has been recognized by a broad spectrum of organizations and publications. In 1995, she was the first physician under the age of 40 and the first African-American woman to be elected to the American Medical Association Board of Trustees. Dr. Benjamin is a member of the Institute of Medicine and a fellow of the American Academy of Family Physicians. She has been chosen as a Kellogg National Fellow and Rockefeller Next Generation Leader. Dr. Benjamin in 1998 was the United States recipient of the Nelson Mandela Award for Health and Human Rights. She received the 2000 National Caring Award, which was inspired by Mother Teresa. In 2008, she was honored with the McCarthy Genius Award Fellowship. In 2011, Dr. Benjamin became the recipient of the Chairman's Award at the 42nd NAACP Image Awards. In May 2013, Reader's Digest ranked her number 22 of the 100 most trusted people in America. Dr. Benjamin has a Bachelor of Science degree in chemistry from Xavier University, New Orleans, attended Morehouse School of Medicine, earned an MD from the University of Alabama at Birmingham, and an MBA from Tulane University. She is the recipient of 30 honorary degrees, and I think she's just getting started. We are indeed honored to have with us this evening Dr. Regina Benjamin. Please.
So hello, make sure you guys can hear me. Good. So nice to be here with you. Thank you very much. And thank you, Dr. Fell, President Fell. I also want to just thank the University of Findlay and the College of Pharmacy for inviting me and to join you with this first ever social justice event. But before I get started, I want to kind of tell you what a Surgeon General is, because most people ask me, what did the Surgeon General do? The Surgeon General actually has two roles, and one is as America's doctor, and that's where I give the American people the best information available at the time so that they can make good, healthy choices, healthy decisions. Things like around healthy eating, smoking campaigns, all of those type of public health issues. And the second role is as, the first role also you may notice is anti-smoking and having the Surgeon General's warning on cigarette packages. But the second role is as the 3-star admiral of the United States Public Health Service Corps, where, as was said, I commanded 2,500 officers around the world. And these officers are a branch of the military. We're a separate branch, just like the Air Force protects our skies, the Navy protects our shores, we protect the public's health. And we're around the world to surveillance and prevent outbreaks and things like that. So if you have more questions about what the Surgeon General does, we can talk about it more. The other thing I wanted to mention is that my little town of Biola Battery, because I'll refer to it a few times, it's a little fishing village along the Gulf Coast of Alabama. And many of you have probably heard of it because it was the town in the movie Forrest Gump. And it's very diverse. We have about 60% white, which are, again, fishermen, shrimpers, oystermen, 30% Asian, Cambodian, Laotian, Vietnamese, and about 10% Black and other. And that's not typically what you think of when you think of rural Southern Alabama. But again, thank you, University of Findlay, particularly the College of Pharmacy students, for inviting me to this. And I'm really impressed with your first ever social justice event. And I also want to thank those of you who are joining from the community and supporting these students. I'd love to commend the strong leadership of these students and commend the visionary faculty and administration who support them in this effort. Today, more than ever, it's important for us to come together like we are right now this evening. You're often told that you are our future, and that's correct. But I also want you to know that the future is now, and it's up to you now. Particularly in healthcare, the roles that each one of us have to play are increasingly important to the patients we serve and the communities we serve. Especially now with the changing regulations, the aging population, changes in payment models, and more emphasis on value-based care. Traditionally, the focus has been on more and more healthcare cost and utilization, but we're now having to focus on quality and healthcare outcomes, especially during this time of COVID. All of this makes the work that you do or will do so very important. Quality and improved health outcomes depends on us having the right knowledge and the right tools and the right devices, such as technology. But it also depends on us being able to communicate with our patients. It depends on our patients being able to communicate and understand us, but more importantly, on us understanding our patients. So I thought I'd share with you a little bit about my community experience and my clinical practice, as well as some of the work that I have done as Surgeon General. And all of this is to hopefully stimulate your thoughts on how you, during your everyday actions, can make a difference. When I was an intern, right out of medical school, I attended the Medical Association of Georgia's annual meeting. And one of the intense issues that was being debated was that sexually transmitted diseases needed to be taught in medical school. Well, I stood up in a room with maybe 15, 20 people, and I told them I had never seen certain diseases except in a textbook. And I thought there was a need. The resolution passed, and the Georgia delegation forwarded that resolution to the American Medical Association. They also took me to the AMA to speak to the same issue, and the resolution passed. And within 6 months, every medical school in this country was encouraged to include sexually transmitted diseases as part of their core curriculums. I learned that one person can make a difference, whether it's in medical policy or in medical practice. And I learned that I could make a difference in medical practice when the National Health Service Corps sent me to Biola Battery. It's a pretty place, but it's a poor place. I found a community of working poor, too poor to afford medical care, but too rich to qualify for Medicaid. I like the people, I like the community, and I wanted to practice medicine there. But I quickly learned that practicing medicine wasn't just sewing up the shark bites. I had to deal with the land sharks, as I call them, the regulators, the reviewers, the red tape dispensers. And by the way, not knowing that I was going to become one of them at some point, but I had to find ways to stay involved in my, to address these issues. So I stayed involved in every organization there was. I stayed involved in the AMA, the Academy of Family Physicians, our medical society, our United Way, the Red Cross, Girl Scouts, Chamber of Commerce, any organization that I could be a part of to help get services into my community. I learned that my patients had problems that my prescription pad alone could not solve. things like adequate housing, especially after Katrina, employment opportunities, clean water. When I first went into practice, I noticed that the bayou was dirty, it was black. And a bayou is a body of water that looks like a river, but it doesn't really have a beginning, but it empties out into an open body of water. In our case, it opens out into the bay, into the Gulf of Mexico. But it was black. And the reason was because the shrimpers, the way they changed their oil in their boats was they emptied oil in the water and put more oil in the boat. So I just went round and around trying to figure out how could I get this addressed. The health department said it wasn't their area of jurisdiction. The EPA or whatever equivalent of our state, it wasn't their area. The Corps of Engineers, I just could not find anyone who said it was in their jurisdiction. So we got together and we just decided to put some barrels right on the pier where the boats come in. And as they came in, we'd just put a note up there and asking them to put the oil in the barrels. And they did, because the shrimpers wasn't trying to pollute or anything. They started putting the oil in the barrels, and slowly the water started clearing up. And it was just common sense. It just started clearing up. And that didn't take a lot, but it made a whole difference in the clean water, the way people thought about things. Those little solutions can make big differences. I had a patient, and I'll tell you about a couple of patients if you don't mind. Donna, 20-something-year-old white young lady who had two kids. And Donna had seizures, and she came in one day, and her seizures had been under control, but she came in and she told me, well, she had started having seizures again. And I said, well, did you miss any of your medicines or anything different? And she drew for me on the paper, because I always tell people to write things down so they don't forget when they come in and we get to talking or something. So she drew for me her pills, and she said she drew what they look like. And she said that our pharmacist, Jim, she used to take one solid and 2 stripes pills, but now they were all stripes. And what had happened was that our Medicaid program, state Medicaid, had gone to generics medications, and she didn't know the difference. And I realized at the point that Donna couldn't read. 20-something years old in today's world and could not read. And it didn't matter how many prescriptions I wrote for her, she needed some adult literacy. And so we worked to get adult literacy program from neighboring Mobile to come down once a week and start having classes. And that to me helped her more than any prescription I could write. And I'll tell you about one other, and that's Miss Smith. Miss Smith, of course, all of these are their HIPAA names, as you guys know. I'll call her Miss Smith. And Miss Smith was I guess she's mid-30s, late 30s year old African-American lady, fairly short, and she was slightly overweight. And Miss Smith called me on a Saturday. And I always tell patients they can call me if they need to, and they never abuse it if they call in and something's going on and serious. So I said, I answered the phone and said, Miss Smith, what can I do for you? And she was saying, well, Dr. Benjamin, my back is really, really hurting. She said, I went to see that specialist you told me. He said I have a slipped disc, and he gave me some ibuprofen, and it's just not helping. It's not strong enough. Can you call me something in stronger? And I said, sure. I could hear it in her voice that she was in pain. And I said, Miss Smith, I'll call you in something, but you got to come and see me on Monday or Tuesday. She says, I promise I will. And sure enough, I called her in something. And on Tuesday, I was in the office and I walked in the exam room and there she was, leaning over the exam table. She was in so much pain, she couldn't sit down. And I said, Miss Smith, did the medicine I called you in, did it help at all? And she says, well, Dr. Benjamin, I didn't get it. So what do you mean you didn't get it? She says, I couldn't afford it. I said, but you work at the school system. You're in the janitorial service. You work in the school system. You have insurance. She says, I know, but I just don't have the copay. But I get paid on Friday and I promise you I'll get it. And so I walked out the exam room and I went to Nell, my nurse, and had her go across the street to Jim to get her medicine filled. And then I walked back and I had the medicine. I walked back in the exam room and I said, Miss Smith, I can see you're in a lot of pain. Here's your medicine. I want you to start taking it. And at that moment, her eyes welled up with tears. And she says, oh, Dr. Benjamin, I'm so embarrassed. I didn't want you to have to do that. And at that moment, I realized that cultural competency has nothing to do with the color of your skin. It has to do with allowing people to maintain their dignity. And so I had to figure out how to get out of that. And I told her the fact that we have a small pot of money that people donate to us just for times like this and for situations like this. And I could see her, face turning, and I said, you can pay it back if you want to, but we really prefer that you didn't, because that's what the money's for. And she was okay with that. And as I was leaving the exam room, she says, oh, by the way. And I said, as a doctor, you wonder what this oh, by the way is going to be. But she says, oh, by the way, can I get a work excuse? And I said, sure, you can get a work excuse. Start taking your medicine. Today's Tuesday. You want to go back on Thursday or Friday when you're feeling better? She says, oh, no, we have to strip those floors tonight. Here was a woman in so much pain that she can't even sit down, but she's willing to strip the wax off the floors so that our kids can go to school in a clean environment. And so it was for her and Donna and people like her that I agreed when President Obama asked me to become the Surgeon General to accept it. And it was with mixed feelings because I'd been in solo practice for 23 years at the time. But I agreed to leave my patients so that I could go to Washington and be a voice for them and give them a voice at the table. But I did realize once I got there that I would have 300 million Americans as my new patients. So I didn't lose patients, I gained patients. Access to care at the time was at the forefront of our public discourse, and sadly, it's at that forefront again. And while many of us believe that giving all Americans healthcare coverage is the first step in truly reducing our health disparities, the ones that plague our country, but we also know that to reduce and ultimately eliminate health disparities, we have to address the social determinants of health, such as poverty. Your zip code is a better predictor of your health and longevity than your genetic code. A study published in the American Journal of Public Health showed that poverty and dropout rates are at least as important a health problem as smoking is in the United States. I can't underestimate to you, or can't overestimate to you, I guess, the importance of education. The health differences between the more educated and the less educated are significant. The US death rate for people with less than 12 years of education is 2.5 times higher than for those with 13 or more years of education. An additional 4 years of education was found to lower the 5-year mortality, reduce the risk of heart disease and of diabetes by 10 percentage points each. Just by getting a high school diploma, not doing anything different, not making any different amount of money, just by being educated, impacts your health. I'm a longtime champion for the power of prevention, and prevention is the foundation of the public health system, and it was the foundation of my work as Surgeon General. Health does not occur in the doctor's office and the hospitals only. Health also occurs where we live, where we learn, where we work, where we play, where we pray. Health is in everything that we do. And I believe that prevention offers the greatest opportunity to improve our health of the American families for now and for decades to come. I also believe that prevention is the key to building a stronger and more sustainable healthcare system. Prevention has become an imperative, and that's really largely due to the changing dynamics and the demographics as more American families struggle to deal with chronic diseases like diabetes and hypertension and strokes, behavioral and mental health issues, and the tragic toll that they take, both personally and financially. I know that you guys probably know this, but almost 50% of adults have at least one chronic condition. This year, more than 800,000 Americans will die from heart disease. And the overall cost resulting from cardiovascular disease is estimated to be $444 billion every year. And there's so many more statistics to tell the same story. We have to make prevention part of our everyday lives and empower people to make better health choices. So I was pleased to have been a part of the administration when we launched this really broad agenda to help Americans get healthy, live longer, and stay well and thrive. And as was mentioned in the introduction, I had the privilege of chairing the National Prevention, Health Promotion, and Public Health Council that was consisted of 17 cabinet heads of agencies like the Department of Transportation, Department of Education, the Secretary of Labor, EPA, HUD, Defense, all of them for the first time ever to sit around a table to talk about prevention. And our council released the first ever National Prevention Strategy, which is America's plan for health and wellness. And our vision was and still is to move our healthcare system from a focus on sickness and disease to a focus on wellness and prevention. In addition to the state-of-the-art medicine that we have, we also need this new approach to promoting prevention in our communities, since staying healthy depends on other factors that influence our health, like housing and transportation, education, the availability of quality, affordable foods, our workplaces, and our environment. We have to change the way we think about health in this country. And that calls for us to take a more holistic and integrative approach to community health. Everything from safe highways and worksite wellness programs to clean air and healthy foods. And nothing has made this more clear than this past year with COVID-19. We have to get to a place where everybody understands that everything that we do, even though it's not labeled health or prevention, really does affect the health, quality, and length of life of all Americans. And finally, the goal of the national prevention is to increase the number of Americans who are healthy at every stage of life. It's like one of my patients said, she said, I want to get old, but I want to be upright. But becoming a more healthy and fit nation is going to require more than just educating the public and creating these piecemeal programs. It's going to require a group of dedicated leaders just like you to lead that charge. And that brings me to leadership. And I just want to take a couple of minutes to talk about my two favorite styles of leadership. One you all heard of is the servant leader. That leader, you heard about him throughout history, throughout church. They do things not for the glory, not for the the attention, but just because it needs to be done. And they lead by serving. And I think that the President's Student Council on Belonging is one of those examples. President Feld didn't have to put together this student council, but she does. And there are so many other things that she could be doing, but she's putting that together and trying to have a more open culture and wanting the institution and the entire community to do better, trying to make everybody feel at home. And in her words, she likes that power of kindness. And that's what we see in servant leaders. We're seeing it in the students that put this program together. They are serving you, and they will be serving the patients that they treat and the communities that they're in as they leave pretty shortly to come out to join us in the healthcare workforce. My other style of leadership is one that I kind of made up by name. I mean, I call it leadership from behind. And that is when you rise to a certain level of success, that you don't forget to reach back and pull others up with you. And that's the sign of a good leader. But a great leader won't stop there. A great leader will push you out in front of them and push them out and make them even better than they are. And like young people say, we will let them know we've got their back. And that when you let them know you have their back, that if they stumble, they won't fall because you're there to catch them. I'm sure that your faculty members and your teachers and professors will be there even after you guys, the P6s leave and others and other careers leave. You can always call back on them. Leadership from behind. We also need to encourage more minorities to enter the health professions. Less than 6% of the physicians are minority. 30% of the population is minority, but less than 6% of physicians. And that's the same percentage during the Flexner Report of 1910. We see the same sort of numbers and percentages in pharmacists, in other professions, dentists, nurses, other health careers. You are the folks that are going to be the examples. You never know who's watching you. It may be your little cousin, it may be the kid down the street, it may be just people around you. They're looking and they're seeing you by what you do, and you're leading just by being successful yourselves. And just remember that you do have people watching you. When I would get my name in the paper or something, I would think, yeah, it's nice. But I remember one time a reporter called me to want to interview me, and this was, I was in practice, and reporters want to ask you the same questions. I mean, I guess they want their own quote, and I didn't understand that back then, but I just saw it taking me out of the patient's out of the exam room so I could sit and take this phone call. And so I was always, putting it off, dreading it, until one day I did an interview, and it ended up in the paper. And a few days later, a week later, I got a manila envelope in the mail, and it was filled with letters from a second grade class. And each one of them said, "I saw you in the paper. I want to be a doctor just like you." And I realized that those interviews, those awards I win, all of those things have nothing, they're not about me. They're about one of those second graders wanting to be either a doctor or a nurse or whatever they want to be. That's what makes it worthwhile, that they are looking at you. I also had a time when I was, as was mentioned, I was on the American Medical Association Board of Trustees, and in medicine, that's a big deal. I mean, you get elected, and it's like a big campaign. It's like running for Congress almost. But Being on the AMA board, we had the annual meeting, and it's at a big hotel in Chicago. All of this is pre-COVID, of course. And during the annual meeting, you know, the board had a boardroom and set up in one of the rooms, and it was a big board table where we all sat around a table. We had a microphone each, and in between the conference, you know, we would sometimes have meetings or whatever. And I went back to the boardroom to get something off of my table, off the desk where I'd left it. And there was a janitor there, an older Black gentleman who was cleaning up. And he said to me, "Ma'am, can I say something to you?" You know, I was taken aback, and I was like, "Of course." He says, "I want you to know that we all know you're here, and we're very proud of you. I even told my granddaughter about you. You never know who's watching you. And so I want you guys to always be successful, always do things, but you are making a difference just by being where you are. And don't ever underestimate that. But while you're doing that, also make some time for yourself. Your own emotional health is so important, and you can lead by example with that as well. When we used to fly prior to COVID, we would say that the flight attendant would say, "Put your own face mask on before attempting to help others." You can't help others if you're not in any condition to do. I guess once we get back on the planes, I guess we'll already have face masks on from COVID face masks. So it's a little different. I wonder how they're going to change that announcement. But I want you to rest, exercise, play, have fun, stay in touch with your friends, your classmates. You're making lifelong friends that will be with you the rest of your lives, and stay in touch with them. And I guess finally, I'd say make sure you do the 3 W's. I wouldn't be a good public health person if I didn't tell you to do the 3 W's. Wash your hands, wear your mask, and watch your distance, and get vaccinated. I want to open it up for questions, but I'm from an area where we always tell stories, and I want to end with a story about, there was a young lady who was jogging down the beach early one morning, and many of you probably heard this story, but she was jogging down the beach early one morning, and there was this gentleman tossing these starfish in the water one at a time. And as she was jogging, she saw him tossing these starfish in the water, and there were hundreds of starfish. So by the time she finished her run, she just couldn't take it anymore. So she went up to him and she asked him, "Why are you tossing those starfish in the water one at a time? There are hundreds and hundreds of starfish along the beach. The sun's going to come up, dry them all out, and it's not going to make a difference. Why are you bothering?" And he looked at her, looked down, picked up a starfish and said, "It makes a difference to this starfish." And he tossed it in the water. I want you guys to find your starfish and make a difference. Thanks.
All right. On behalf of everyone on the Zoom webinar this evening, thank you so much, Dr. Benjamin, for a truly memorable and inspiring keynote. We will now go ahead and transition into the questions and answers portion of this evening. I'm sure that everyone has a lot of questions to ask you. And before we go ahead and do that, I'll go ahead and introduce myself, and then I will move it on over to Nick. So my name is Victoria Ayola. I am a 5th-year pharmacy student here, dual majoring in the Masters of Health Informatics program. It is a pleasure to be with all of you this evening.
Hello, everybody. And I will say thank you as well to Dr. Benjamin. I really appreciate the talk and everything, and I'm really appreciating the time that you're devoting to all of this. My name is Nick Reed. I'm from Upper Sandusky, Ohio. I'm in the P6 class, so my final year. and I'm also dual majoring in my MBA. So the way this Q&A session will kind of run, as you can kind of see, and as was explained at the beginning, there is the Q&A function for you guys to submit questions, and then Victoria and I will be, kind of going through all these questions to pass off to Dr. Benjamin. We may not get to all of them. We may get to most of them, but nonetheless, we will do our best. And with that, Victoria, I will hand it off to you for the first question.
Thank you so much, Nick. All righty. So the first question we have for you, Dr. Benjamin, what would you encourage faculty and teachers to share with their learners to prepare them for careers in a world with diverse people and needs?
The faculty is often, you spend so much time with them, and they are, they're setting those examples. And I would encourage them, which they already know, but to lead by example, by doing the right things. The best things that they can share with you is challenging you, asking you questions to make you think. If they can teach you how to think, all the rest will come in place. I mean, there's basic knowledge, of course, that you're going to have to get, and you will get that. But thinking for you, teaching you to think critically, particularly in whatever their special area of teaching is, that prepares you for whatever may come up.
Follow-up question here is, and this is a fairly broad question for you, but what's an ideal first step to ensuring that those in underserved or unrecognized communities, especially minority and geriatric communities, get access to and assistance with some of the appropriate and affordable healthcare?
Yeah, that's what I've been doing all my life. I went to business school, as you know. I have an MBA. And the reason I did was that I wanted, when I went into practice, I realized I didn't know anything about business. And oh my God, well, I'll just get an MBA. Well, it wasn't quite as easy. Getting an MBA is probably harder than going to medical school. But I went because I wanted to figure out a way to deliver quality, affordable care to people who wouldn't otherwise have it. And I'm still trying to figure that out. We haven't gotten there yet, so we're going to need your help. But for rural communities and some of the areas, particularly the underserved areas, is a challenge. Trying to get healthcare workforce to those communities, to those areas. So we're trying to come up with model innovative ways to do that. Because of COVID, telemedicine, telehealth has become much more acceptable now, and we can reach more people in more settings than we could before, and that increases access. But everybody doesn't have the technology. They may. Most of you guys probably have cell phones, and some people, you guys just have only a cell phone. But in some of the rural communities, they only have landlines. And they still only have landlines. So it's a mixture. And then others who don't have internet, and so don't have internet access. So we have to try to make that infrastructure available to everyone. And that's one of the challenges, but we can do that. We can do that as a nation, I think. And we just have to have the will to do it. The other thing is to make sure that these companies who are developing technology or developing medications, make those available to everyone. So I've spent the last few years serving on some corporate boards, actually through a couple of public boards and some startups. But the reason I'm there, and everyone knows why I'm there, is to make sure that if being at that board table is where the decisions are being made about where we will be putting our products, where you'll be going, and that I want to make sure that they're accessible to the people I serve, and that it's not all about making the most profit. You have to make a profit, but you don't have to make the most profit. You can be much more profitable if you spread it out. And in the business world, they call it scaling. The more people, the better.
Thank you so much for your answer to that question. The next question I have here is more specific about your time. So the question is, can you discuss how your time leading the Commission Corps as Surgeon General fulfilled your desire for health equity in the United States?
The young men and women who, and officers, and I say they're all officers, so they all have an advanced degree in health in either, in pharmacy or medicine or nursing, or they are such a dedicated group of individuals, and they come with that dedication to serve, and they're willing to do things for the good of others. So as I say, they're commissioned like a branch of the military. I can't ask a civilian to go into harm's way, but I could deploy the commissioned officers to go into places. For example, when we had an outbreak of Ebola, you hear, well, CDC sent this team there. Well, that team is mine. And I would have to deploy them and get them on, alert and be ready to move. And so they would go there, contain whatever the illness or the outbreak is, so that it didn't spread around the country, and we would treat it no matter where in the world. So it was one of those things that we're surveillancing the world, providing prevention, providing that, particularly around infections and disease outbreaks. So that in itself was just a sense of pride to have these professionals all around the world dedicated to keeping us safe from a public health perspective.
Very cool. Very cool. Thank you. This one hits pretty close to home with everything going on with COVID, but, in, the line of work of healthcare, how do you personally manage what we would kind of deem compassion fatigue, or, kind of burnout with everything going on?
It's been pretty tough here. A couple of things on that topic. I think you're never prepared for it, but in my area, we went through Katrina. And Katrina, we've gone through a lot of hurricanes. We've gone through, and I didn't talk about that. I've gone through Hurricane George, and it destroyed my practice. I had to rebuild it, and I worked out of my truck doing house calls for about 2 years to rebuild it. And then we had another hurricane, and then we had Katrina. And then after Katrina, I had a fire that destroyed the whole practice, New Year's, just before reopening it. But especially during Katrina, we started experience that compassion fatigue. After a couple of years, because that was several years, 10 years to recover from that, because it was so widespread. So many of us kind of knew that. And then again, in our part of the country, we had the oil spill, and the oil spill devastated the area. And so it was a double hit on people and their emotion and their mental health, and just having to be resilient. And over time, we're learning how to be resilient. From a medical standpoint, whenever I ask a person, when was your last tetanus? They can tell you because it's around some hurricane and they knew when it was going to be. But you're preparing for it before it happens. There are certain other things you prepared for. With COVID, it's harder because it was the entire world. It wasn't just us, and there was nowhere to turn for, comfort or help or anything, because they're suffering too, wherever you are. And so this has been an entire pandemic around the world, and we're in all of this together. But one of the things I hope, and particularly around the beginning of COVID, about this time last year, when everyone was locked down, and when everyone felt like, I don't know where my next paycheck is coming from. I don't know if I'm going to be able to pay my rent. I don't know if I'm going to be able to get childcare. All of those things we were going through is what poor people go through every single day. And they go through it. And I hope that we get some sort of compassion and understanding and empathy for what they're going through, because we would typically say, well, why don't they just get a job? Why don't they just? Now I hope people will understand it's not that easy. And so I hope we don't have too much compassion fatigue. I do hope that we will continue those acts of kindness, because that's what regenerates us and that's what makes us feel better. We're starting to open things up. Hopefully, we can continue that without something to stop it, like variants or something. But with that, doing something for someone else really energizes you. And if you don't believe me, try it and see what happens.
Thank you so much for that. We have a couple more questions here. Our next question is, with significant racial and ethnic health disparities, what are 2 to 3 areas that we can address to eliminate these disparities?
Health disparities, we've been working on those for a long time. And I think we've come far, because early on when we first started recognizing that we had the health disparities, people naturally didn't want to accept that it was true. You would ask me and I'd say, no, I treat everybody the same. And I don't, but then I could see that, when you start looking at the numbers, and that's why we always say measure something so you can improve it. How many people have their blood pressure controlled? It's not how many people came in and got their blood pressure checked or I wrote a prescription for me, but how many of them kept their blood pressure controlled. And so there were so many differences. There are cultural differences. And I talk about oftentimes I'm on the board of American Heart Association. So I'll talk about the fact that my mother had her first heart attack before she was 40. And she actually, I talk about her a lot, but she didn't die of a heart attack. She died of lung cancer because she smoked and started smoking as a teenager, because her twin brother was smoking and he was a boy and they let him smoke, but they wouldn't let her. And she said when she got old enough, she was going to be smoked too. And so both of those things are preventable. That's my point with that. But when she had her heart attack, she kept saying it's gas. It's gas. It's indigestion. It's gas. Went to the doctor. They said it's a heart attack. And she says, the doctor told me that gas cut my heart and left a scar. It's always going to be gas. And so early days, we didn't take women's symptoms as different. And so we have to do that. And it's the same thing with different cultures, is learning differences. But those were the times we were trying to identify and recognize health disparities, and we wanted to decrease them. Today, our goal is to eliminate health disparities, not to just decrease them, but we need to eliminate them. And the only way we're going to do that is by addressing some of these social determinants of health. A few of the ones I spoke of, but your financial health is directly related to your physical health. Teaching someone how to balance their checkbook or write a resume is as impactful to their health and the health of their family as anything else, as eating right and exercising, which of course we should all do. But those social determinants of health are really what we as a country haven't really started to address until now. We're just starting to talk about them. Good, healthy foods. It should be, it shouldn't cost more to eat healthy. It shouldn't be more expensive. As we always said, we have to make the healthy choices the easy choices and the affordable choices. And right now, if it says healthy on it, it's going to be more expensive, and it shouldn't be that way. So eliminating those health disparities is what my goal is today, and getting there.
So personal interest question here for you, Dr. Benjamin. What was your favorite part of being Surgeon General?
Favorite part? Just meeting people. I got to meet so many people, and take a lot of selfies with people, but I really got to meet a lot of people and go. I like people, so that's just my thing. But also putting into place some things that really hopefully will make a difference in people's lives. At the end of the day, government doesn't work really fast, but it does work, and so just being able to see that it works. The National Prevention Strategy, for example, is one that's being used all over the country and in different countries. In Chicago, it's called Healthy Chicago. San Diego has a name for it. The state of Massachusetts is using it and they're calling it something. The country of Sweden adopted it. So just seeing those things be put in place. And there's a couple of large hospital systems that are using it as a roadmap. I did another one that came up earlier today. Is I released a breastfeeding report, and it was the first report on breastfeeding, and just the fact that it is still being used today, and that was over 10 years ago. That mothers, we have to support mothers who want to breastfeed, and not make those who don't want to breastfeed feel bad, but those who want to breastfeed, we need to support them and have them understand that a child who is exclusively breastfed for the first 6 months of life is less likely to become obese. We know about the antibodies and all the things that it gets from his mom, but the mom also has protection. She has protection against less likely to have breast cancer and some other things that she's also benefiting from breastfeeding. So it's those type things, as being Surgeon General, were really good. But I will tell you, the thing I missed the most was seeing patients and being with patients. And even though I talked to them on the phone and stuff, it wasn't the same.
Thank you so much for sharing that with us. I love hearing that your favorite part is being with the patients. That's amazing. I have another question here. Well, actually, it's kind of asking for your thoughts. What are your thoughts on the statement that America doesn't have a healthcare program, but only a sick care program?
So that goes to our goal with the National Prevention Strategy, is to move us from a system of sickness and disease to one of health and wellness. And that's exactly that. And that's what it means pretty much. And I wouldn't, I mean, that it was often said that way back a few years back, but today I would say that it's an insurance program more so than anything. And so the health program and the healthcare system really needs to become the center of things, and not the payment models, because the payment models has slowed down what, some of the things we can do. I do believe that COVID is going to help some of that. And by improving those access to care, I mentioned telemedicine because we recently released a report before Christmas on telemedicine, but being able to have a single mom who can't necessarily go and get her routine blood pressure checks or whatever, going to the doctor. She can't afford to take off a day, afternoon or something, but she can afford to, during her lunch break, to find a quiet place and have her visit with her clinician over the video conferencing. That will improve her outcomes, just because she'll be in touch and be able to stay in touch with her clinicians much better. And that in itself will improve some of the access issues we have. I think putting more information at a patient's hands and letting them make good, healthy decisions is going to also improve health outcomes and improve the way we're more of a healthier society, healthier community. I hope that the communities will get more involved in making it like clean air and walkable cities, and making it so that we have safe places to exercise, safe places to go, although we'll wear our mask.
So, on the topic of COVID, and I think it's something we've all kind of faced this year, is what's your advice on how we as healthcare professionals can combat, misinformation and medical mistrust?
So there is a lot of that out there, and I don't have to tell you guys. It's like I've been trying to overcome that all year long, and trying to keep up with the information is our first challenge as healthcare clinicians or professionals. We have to keep up with the ever changing because it will change and it's dynamic. And so what we did today is not what we did last year this time. It may be similar, but it may be different. So it's important that we keep up, and then we counter any of those misinformations out there. When our friends and our colleagues or whatever will say something, find the facts, find the science, and follow the science, and don't let little things go. I think it's important that we get vaccinated ourselves. Again, leading by example, showing, because people are watching you. When you have a nurse that says, I'm not going to get vaccinated right now, that makes people think twice. We have some national campaigns going on vaccine hesitancy. One is with the Ad Council, and you've probably seen a lot of those ads. One was with, the first set was with the former presidents of the United States that came out, and then we have some others, and one came out with Morgan Freeman yesterday. So we have some celebrities, those sort of things kind of help. And when you see people, but as health professionals, people are looking directly at us. And these are, this is something people trust us. I mean, as a doctor or as a nurse or other health professionals, a mom will come in and hand you her baby and put her baby in your arms, and you're a total stranger to her. And she's gonna, because she trusts you. She trusts you because of that you are a health professional. And she wouldn't put her baby in the arms of another stranger otherwise. So that trust requires that we hold that trust to be sacred, and that we honor that trust by giving them the right information in what we can. I've come across a lot of different excuses for people not taking the vaccines, and I'm not sure what you guys are hearing, but I will tell you that a couple of the myths that are out there, well, not say myths, a couple of the concerns early on in the African American community, we wanted to address the mistrust and to show that we're watching this. And as I told people, I will never recommend you take something that I'm not convinced is safe. And so I would not recommend a vaccine until I had studied it myself and it was safe, and as safe as I can know it to be, so and I've only studied a few of them, but those that I have, they meet my criteria, and I got vaccinated. But there are other things, and particularly in the African American community, around trust and prior not mistrust, prior misbehavior of the healthcare system. And I have a personal connection to the Tuskegee experiment, so I can speak to that. So, and I have, and I'll tell you that a couple of personal things. One is that my stepmother father was one of those Tuskegee men who were given, or not given. That's the other thing. He was one of the ones experimented on. The doctors and the people who did the experiments were the U.S. Public Health Service that we just talked about. And they were, that was a group that I just led as Surgeon General. And they did it in the state of Alabama, where I became the first president of the Medical Society. They did it with the permission of the Medical Society. And so knowing that these things have been done in the past shouldn't, we will not let them happen again. The other thing about the Tuskegee experiment that people sometimes don't think about is that experiment was, they knew these gentlemen had syphilis, but they withheld treatment. They did not treat them. So in this COVID vaccine, we're withholding our own treatment. We shouldn't do the same thing to ourselves. You know, we have a vaccine that can prevent us from getting COVID. We should take it. We shouldn't let our history prevent us from getting our own treatment, right? I mean, our own benefit from the medical medications and things that exist, particularly the vaccine. But Tuskegee was wrong, and we will never forget, and we will work very hard to never let it happen again. And when I was in office, President Obama particularly re-emphasized that we were not going to let it happen again. And prior to us, President Clinton made a national apology and established the Bioethics Institute at Tuskegee. But it's real. And so I think it's important that we do ask the right questions, and that we do make sure that we're, you know, not being mistreated. And so I don't discount them, but I also want to make sure that people understand that we will do the best we can to keep people safe. And also another thing out there, I hear a myth about people will say, can you still have children after you take the vaccine? I don't know if you guys heard that, but a lot. And they talk about the, you know, the RNA and link it to DNA. Well, it's RNA, and it's RNA product. And I don't want to go into too much of the details, but it attaches. And once it attaches to that little spike, it falls apart and is degraded. So it doesn't exist. And it's also not a live virus. So it's never a live virus. And so it doesn't change your DNA, I mean, or can't change it, and it doesn't enter the cell, so it can't change your cellular type. So the answer to that should be no. Long answer for whatever.
Thank you so much for that. And I actually appreciate you for telling us to lead by example. So I hope a lot of us health professionals, future health professionals that are on here have been vaccinated. So my next question here is, do you think that we can successfully provide universal healthcare in the United States?
I hope so at some point. Universal healthcare is a little bit different than having a single payer. And so when you talk about universal healthcare, it gets caught up with the single payer bit. And so in the United States, a lot of people will disagree with me, but I don't think we're going to be able to get to a single payer, because people want to control how they spend their money. And they're not going to let you tell them that they can't spend their money on something. And it's their money. So you can't tell me I can't buy something else or whatever. So I think that's going to be the challenge with single payer. But universal coverage, universal healthcare is, we have to get to a point where we can make sure everybody has healthcare available and coverage is there.
For sure. And I think, you know, that's a big step to take, big leap to take for sure. But in the next question we have is, you know, should we be highlighting certain disease states that are maybe perhaps overlooked in specific populations? I know that's a big overarching question, but, you know, just kind of a curiosity one we had from the audience.
You know, I think we do. I'm not sure which ones the question is referring to, but when we, how should I say, when we have illnesses, particularly what we call orphan conditions, where there are not a lot of drugs to treat them, or drug company doesn't see a big population, so they don't make the drug anymore, that kind of stuff. Those things are really, I think, ethical issues. What we're seeing is many of the groups will get together and start raising their voices, so those voices can be heard, and using their voices to bring in other folks with other voices to highlight them and bring attention to whatever those conditions are. I had a friend who wrote last week that, a friend of their child's had this particular type of brain tumor, but it was being and having seizures because of it. The seizures are being controlled by this experimental drug, but the drug company decided not to continue with it because it was costly, and there weren't that many people with that kind of condition. And so what do you do? And the child was being, controlled. And what do they do now? And as a parent, what do you do when the drug will no longer be available? And we can't make the company make the drug. But there's a group that started forming, is getting together, that's trying to certainly push the company to at least try to make a compassionate drug for that, and other companies to be a part of that as well. So it's not all on one company, but that they don't continue to have it. But that wouldn't happen if that group didn't get together and raise their voices and be advocates and speak out. So I'm not sure if that's what the question was about, but they can ask it differently if it's different.
Thank you so much. This next question, I'm kind of going to morph two questions together here. So it's, do you see gender disparity in the healthcare community? And then do you also see the mistrust of healthcare professions being an issue for women of all races?
So the first question is yes. Now, what was the second? Healthcare? Read the second one again.
Yes, no problem. So do you also see the mistrust of healthcare professions being an issue for women of all races?
I guess I don't quite understand the second question, but is it asking that or how do you interpret it? Are you asking, do women see a mistrust in the health professions, or the health professions seeing a mistrust in women?
Yeah,
sure.
and actually they elaborated on this. So they read a recent book by Doonesbury's Doing Harm, having shed light on this issue of mistrust. And they were just curious on your take on that. If you've read that book.
I have not, but I do. There is certainly, we just got off Women Month and Women's Heart Month, and we have a ways to go in gender in this country and other countries too, in every aspect of it. When throughout it, and I could just tell you today it's better, but it's still an issue. When I was running for the Medical Association in Alabama, there was, we didn't have many women, so I should say. I remember running. So when you're running, you're campaigning, you go around at the meeting, and this is the Medical Association in Alabama now. So that was, you go around to different rooms and to the different little regions or cities or whatever, their little caucuses, and you make a speech. And so there was this white doctor who, I didn't really know him, but he saw me getting ready to walk. He says, you have anybody walking with you? And I'm like, no. And he said, I'll walk with you. And he did. And I didn't realize at the time, but he was a past president. He's like a godfather for the place. I didn't appreciate it at the time. But we walked in one of the rooms, and this tall gentleman stood up, and the guy walking with me, his name is Bill. And he said, and the guy who stood up, I was getting ready to give my speech, and he said, now, Bill, that ain't right. We don't need a Black person on this board. And besides, we got one woman anyway. And so Bill was getting ready to talk, and I just told him, you know, I'll handle this. And I just said, I'm not running as a Black woman. I'm not running as a Black person. I'm not running as a woman. I'm running as the most qualified doctor. And so if you don't think I am, you don't have to vote for me. And I went on with my speech. And, you know, those are different times, but he became one of my strongest supporters throughout the year as the years went on. That was where he was in his life at the time. And I wasn't going to take his problems on as mine. That was his issues that he had to deal with, and I went on. But he did become a real strong supporter. So through the years, and the AMA didn't have very many women either. And through the years, we had to work twice as hard. And as it goes, it's fortunately that's not too hard to do. So, but we really often have to prove ourselves. So at this point in life, hopefully you don't have to prove yourselves as women. Now you just go do the job. You know, there's been other people ahead of you, so just go do it and do it well. And we always knew we could do it well, and now it's up to you to prove that and show that. We need equity in pay. We need equity in positions and leadership. The boards that I told you that I serve on, every one of them, I'm constantly asking, you know, how many women are in management, how many are in leadership, and what's the pay equity? You have to challenge it, and you can't. I've been involved with Catholic healthcare a lot, and one of the things I remember the nuns would always say when these search firms come back with a list of all guys, they said, well, you know, where the women? And they would say, well, these are the best candidates. And they said, well, we're paying you, go back and find some more. At least you can find some, give us a slate. And once they realize you need a slate, they will go find some very good candidates. And you don't just take no for an answer. These are, I think these are good times for women to be showing our stuff because it's, you know, it is time, long overdue. I think we've got a few good guys out there too, so I don't want to, you know, have them to think that they're not going to be pretty good too. We always need you guys, but you also need people who are your allies and people who will sponsor you and support you. It's like Bill. I didn't know him, but he apparently knew me, and his credibility made a big difference in how others thought of me because they respected him. But he didn't have to do that. And so you see people trying to move up. You can be that mentor for them. You can be that sponsor for them. And a difference of sponsor, you know, sometimes you know, I don't even know who my sponsors were because people will support you and you don't even know it. They don't have to sit and mentor you one every day or, you know, talk to you all the time. They can be in a situation. They say, do you know this person? No, but I've heard she's really great and she's worth looking into, you know, that kind of thing. Those make a big difference in our world. And the challenges are real. So again, take care of yourselves and keep those connections because you need those friendships. You need those mental health, behavioral health depends on reaching out to your friends and crying on their shoulder sometimes, bragging when you got something done right and sharing those things as well. All of those things are part of, you know, making us really healthy as a whole person.
So we've been getting a lot of questions in the Q&A from, you know, different healthcare specialties, whether it be occupational therapists, physical therapists, pharmacists, so on and so forth. And, you know, in the interest of time, you know, a question that kind of brings it all together is kind of, you know, what advice can you provide on, you know, interprofessional education, maybe even communication among those different healthcare professionals to kind of provide, our clients, patients with a more holistic, client-centered care?
Yeah, I think the team approach is the answer. I mean, we can't do things without teams. I'm a family physician, and I rely on the whole team. And as we talk about integrated care now, and the other thing around teams, which was different from years ago, is that as a doctor, we would lead the team. Now it's, as a doctor, I'll lead the team for a little bit, then when it comes to a medication or something, I need the pharmacist to lead that team. And it may come to the point when it's time for a person to get ready to, go back into the work field. An occupational health therapist needs to tell me what they need to do. We need to treat that whole patient, and we need to treat them as a team and communicate with each other. And technology is helping that. I think the medical record helps that, but there's nothing like talking face to face and at least coming together some way to bring that patient together as a team and finding out where that you're all in the same goal. So if I want to do surgery on a patient and the the nutritionist just gave them a meal, that surgery is put off for a whole day because they didn't know. I mean, or if the nutritionist didn't come by and say you need certain adjustments to the food, the medication that the pharmacist gives them may be interfered with. So as a team, and I would say that's the one thing I'd say, and with the other health professionals besides the pharmacists and the physicians, I'd say don't underestimate the importance of your jobs, because it is so important to those patients that what you're doing really changes their lives and impacts their lives, and you should be proud of the work you're doing.
Thank you so much for that. Now we're almost at time, but I actually have one question that was provided here. So earlier in your keynote, you talked about the numbers of people of color, African Americans that are in the health professional field. So what is your advice for people of color, minorities who, want to break the ice and get in there and, keep America healthy?
First thing I'd say, if you have any interest in any health career, we need you. So that's the first thing. We really need you. And that's of any area. I also think people from, particularly young people from rural areas, fit into that as well, because you don't have the same opportunities. Just encourage folks to, especially early on in junior high, take algebra, because if they don't take algebra, they're probably going to go in a different direction, and then they'll have to try to catch up, and it's harder to catch up. Just keep your options open. I'll hear kids who say, well, I want to be a basketball player. I'm like, you can be a basketball player and a doctor. You can be a basketball player and a nurse. I mean, it doesn't matter. You can do two things. We multitask all the time, and let kids know that they can. And if you're in a career and you've always wanted to do something else, don't be afraid to switch over to whatever it is. It's never too late at all. It's just never too late. And it may be hard, but life is hard anyway. So, it's like you make it easier by doing it with ease. Some people don't want to, when they talk about medicine, they don't want to do all the time. They say, oh, it took 12 years. Well, if you think about it, it takes you 4 years to go to college. It takes 3 years, 2 years to get a master's or whatever, and then another year to get a PhD, oftentimes more. So you've done those 8 years anyway. I mean, and in pharmacy, you guys do 6 years anyway. I mean, so it's not the time. The time is going to pass by no matter what you're doing. So you might as well be doing something you want to do, and then you're setting those examples. But I would encourage young kids to look at medicine. I had never seen a Black doctor before I went to college, and so oftentimes people don't know that they can be. People say, "Is that you always want to be a doctor?" I didn't know, and I wasn't something I said I couldn't do or whatever. I just didn't. It didn't come up in my thought process until I was at Xavier and doing pre-med, and I'm a joiner, and I join everything. And by the way, for those out there, I'm a Delta Sigma Theta, but so just letting you know. So that's.
Well, we'll do one more question here. I know we're running a little ahead of schedule, but that's quite all right. We want to make sure we don't completely wear you out here, Dr. Benjamin. But to kind of bring it all together, as a new medical professional, a lot of us are going to be graduating here, in the next month, even, some of these younger students that are on the call, they're going to be graduating, 2 years really isn't that long, as we all kind of find out. What do you think is, kind of the simplest thing you can do to have the biggest impact on, increasing awareness of the disparities in healthcare that we talked about today?
I think that the awareness is coming full circle because of COVID has brought it out so much. I think more importantly is that speak up in the settings that you're in. When you're with that patient, you may be that patient's only voice, and so speak up for them, be that voice for them when you can, even if it's in the classroom, it doesn't matter where it is. And as a pharmacy student or as a nutritionist, whatever your role is, you have a chance to bring that patient experience to the conversation, because people won't know what that patient is going through unless you let them know. And so be their voice. The other thing I'd say is listen to the patient, because oftentimes, we're on this path that they're sending them through real fast, checking this off. I did that. But did anybody take time to listen to the patient? And that's the only person in that whole system that may listen to the patient is you. And you may have that time to do that, whereas the nurse is off doing her 20 patients, the doctor's off doing their rounds and whatever, and the only person that they can talk to might be you. And so that's important as far as health disparities. I think I didn't see many of the questions, but I see one in here that says, what am I doing now? And I think now I can't figure out how to get back in the chat, but anyway, I saw it. And I still have our clinic in BioLaboratory. We've converted it to not converted it. We have the clinic. In addition to the clinic, I've started a Gulf States Health Policy Research Center where we're addressing health disparities and social determinants of health for the states that border the Gulf of Mexico: Alabama, Mississippi, Louisiana, Texas, and Florida. While we have some of the best, we think the best, but some of the best medical schools and medical facilities, we have the poorest health outcomes. The health rankings of those states are at the lowest. Mississippi and Louisiana's been tied for 49th for a couple of years, and all of them are in the low. So we have to wonder, why are those health rankings and health outcomes so poor? And I believe they're due to social determinants. And so that's what we have an NIH grant working on that and trying to, put out some scholarly papers around that. Things like we found, just things like the number of liquor stores in a square area, how many blocks can be correlated with absenteeism from work, and income, all these other things that are around it just by doing those things. And we get our research ideas from the community themselves. So we have these fellows and we're training them how to be community-based participatory researchers. And they are the ones doing the research and we're supporting them. So that's kind of one of the things I'm doing, and others is like, and so to keep that clinic going, and I'll do talks and speeches and whatever, and just I like trying to make a difference. So I haven't learned to say no.
Thank you so much for that. And we've had a lot of questions that have come in this evening, which is super exciting, but unfortunately we can't get to all of them. But to kind of like conclude everything, it looks like everyone is very energized about this work. What is your last piece of advice for everyone this evening?
I like to end with a poem, and it's a poem by an unknown author, but I don't know if you know Dr. Benjamin E. Mays. He's a civil rights educator, and he was at Morehouse College, but it was one of his favorite poems, and it's entitled God Minute. And so it goes like this. I have only just a minute, only 60 seconds in it. Forced upon me, can't refuse it, didn't seek it, didn't choose it, but it's up to me to use it. I must suffer if I lose it, give account if I abuse it. Just a tiny little minute, yet eternity is in it. I hope you will take your God minute and make a difference.
Dr. Benjamin, thank you so much for all your words of wisdom tonight, answering the many questions we had, taking the time to talk to little old Findlay, Ohio. We really appreciate it. And it's a little hard to do a Zoom round of applause, but I'm sure we are all, clapping right now. And once again, can't thank you enough for everything. And I know we didn't make it to all the questions and maybe not even all the topics, but it's a big subject area to cover. And I think we're going to continue to work on that. But with that,
well,
once again,
I am so proud of you guys and the students who put this together, and the folks that are on the just taking their evening to listen in, and President Fell just supporting these students. I know you have to be bursting with pride, as I am of them. So thank you guys.
Thank you. And with that, I will hand it off to Jack to close us out. Thank you again.
All right, hello everyone. So my name's Jack. I'm also a last P6 ethnopharmacy program, and I'm currently living in Delaware. I just first off wanted to thank Dr. Benjamin for taking time out of her busy schedule to come talk with us. I mean, myself and the entire student group and everyone in Findlay just greatly appreciates it from the bottom of our heart.
Thank you.
I also wanted to thank our sponsors for helping us put together this event and being able to invite Dr. Benjamin to speak to our campus community. Our sponsors include the Buford Center for Diversity and Service, the College of Pharmacy, the Student Government Association, the UF Convocations Committee, and finally, Walgreens Pharmacy. And finally, I'd like to personally thank all the participants in tonight's discussion. Addressing healthcare disparities and equity is by no means an easy conversation to have, but it is a necessary conversation if we truly want to provide the best care we can provide for our current and future patients. And for anyone in the audience who's interested in furthering this discussion of healthcare disparities, we are offering a short case competition. So you'll be provided a small scenario or patient vignette describing a healthcare disparity or situation and how you as a future healthcare professional could help address this issue or help a patient navigate a healthcare system. For those that are interested, there's a link that Carmen just posted in the chat box for you and department to sign up for. Your submissions will be due midnight this Monday, April 12th. And for any questions regarding the competition, you can direct those to Carmen Witzkin, who provided her email in the chat box as well. Once again, thank you so much, Dr. Benjamin, for kicking off this inaugural discussion that we had, and hopefully we can continue it for years to come.
Thanks. Thank you.
Thank you so much.
All right. Have a good evening, everyone.
Thank you.